Can everyone hear me okay? Good morning and welcome to the Prostate Cafe. This is our monthly meeting. We typically meet the last Friday of each month. And I'm here to answer any and all of your questions about prostate and prostate cancer. I want to thank Jeff, who represents the J&J group, Johnson & Johnson, for sponsoring breakfast, I'm sorry. For me, it's lunch. He has, and Johnson & Johnson has, a very interesting line of drugs. We all know about hormonal therapy, or you probably know about hormonal therapy at this point in time. And hormones generally shut down testosterone production in the body. And since prostate cancer feeds off of testosterone, that does a really good job of shutting down the prostate cancer. You're taking away its food. But it also affects the rest of your body since you're starving the body of testosterone. So it's basically the male menopause, very similar to the female menopause where they lose their estrogens. But there are now newer drugs, and next generation is what we call them. And it's different from the perspective of how it minimizes the exposure of the cancer to the testosterone. And what it basically does is it just does not allow the testosterone to touch the cancer receptor. So it's precise, very precise in its action. So we use this more and more. The name of the drug is called Erleada. It's also known as apalutamide, but it's very effective. We typically do give it, however, in conjunction with what we call primary hormonal therapy, which is the type that I first mentioned that shuts down the production of testosterone. What I've been doing in my patients is starting them on the more formal drug that shuts down the testosterone production, and then kind of tailoring them into the second line or the next generation drugs, such as Erleada, and using that beyond the completion of the primary hormonal therapy, because it has little side effects in that you're not taking away testosterone. They also have another product. It's called Akiga, and this is another interesting drug, but it's used primarily for men who have specific criteria and specific mutations. And Akiga is a PARP inhibitor. And it's very interesting because also there's a PARP protein or enzyme that cancers use to propagate. And this drug shuts down the PARP inhibitor, and it's often given in conjunction with another next generation drug. But again, there's certain criteria that have to be met for that combination to be given. So anyhow, I'll open the floor for questions regarding prostate cancer. Does anyone have any? Yes, sir.
Can you explain, please, the DART therapy that you go through?
So the gentleman's asking about DART radiation, which is something that we do here. It's a type of external beam radiation. Many of you also know that we're pretty much the epicenter for a type of radiation called brachytherapy, whereby you put these tiny little radioactive materials directly into the tumor. And it really is the most precise form of radiation. There is no more precise form of radiation than brachytherapy, not protons, neutrons, photons, or electrons. It's a great therapy, but the bigger picture with prostate cancer is that prostate cancer has this propensity to leave the gland early on and to go to the tissues around them, specifically to these organs we call lymph nodes. And I came to find a long time ago we needed to target those. Brachytherapy was wonderful. It was easily the answer to surgical removal of the prostate, but it wasn't enough. And we needed a better mousetrap. And we began to develop some interesting types of radiation here. And in conjunction with my former team at Memorial Sloan Kettering Cancer Center, and we started at this center actually with something called IMRT. We were the first freestanding center in the world to have intensity modulated radiation therapy. Again, that was developed at Memorial Sloan Kettering Cancer Center in New York, and I grabbed the team and brought them here. But it was a pretty savvy team, and it continues to be a very savvy team. And we've never stopped pushing the envelope, and came to the recognition that while a patient's being treated, the prostate and the targets around it are moving. And that's part and parcel with the prostate because it moves. And all of the organs surrounding the prostate, including the rectum, which is behind it, is pulsating and moving the prostate up, down, right, left. The bladder is on top of it and in front of it, and it's pulsating. Then you have small bowel, large bowel, all interstrewn within the pelvic area, moving around. So things are moving, even pelvic breathing, and you could all put your finger between your belly button and your groin. You'll see you move more than what's important to us, and that's a dot. And so if you're moving more than a dot, it's relevant. And so we came up with a newer type of radiation. It's a fairly recent advent, and we call it DART, and it stands for Dynamic Adaptive Radiation Therapy. And it basically means that we are moving with you. So the treatment is not just a blanket treatment that was designed a long time ago when you first came in, but it's actually dynamic, meaning we're doing it each and every day while you're on treatment. So that's kind of the long and short of it. And it is part of external beam radiation. It's a high energy photons, and we have very high energy linear accelerators here. So we can use an amalgam of different energies per patient, per plan to target the tumors. But with DART, we could not only treat, for example, the prostate, the tissues around it, which may be affected, those lymph nodes that I referred to, but we can also subselect and hyperdose areas within that field to get a higher dose level. Yes, sir.
Does anybody else do DART, or is this the one place that's DART?
Yeah, to my knowledge, we're the only place doing DART. There was attempts to use MRI-guided DART. The problem, and I saw it coming, is that we have to use fast technologies because you're moving and you have to capture motion quickly. And they started using about 2.5 years ago MRI-guided imaging. The problem is, if any of you have had MRIs, you're usually under that MRI scanner for 45 minutes to an hour. And so with each motion, you'd have to wait that long before you change the plan on the fly. So the company went bankrupt. And so that was the only other endeavor to do that. Yes, sir.
Is the beam scan, or is it a large area? Beam scan? Yeah.
Is the beam scanned? I'm not.
Yeah. Are you constantly scanning an area?
We are constantly, yes, he's asking if the beam is scanned. I think he means that are we constantly scanning the area to be treated? And yes, we are. I'm not sure if you're referring to pencil beam radiation. I'm not quite sure, but anyhow. Yeah, it is. It's constantly watching your motion.
And then your breathing is adjusting to the
It
breathing.
is. Yeah, it's called respiratory gating, which watches your breathing patterns and adjusts accordingly. Yes, sir.
Yes, how long after the hormone therapy does it take the body to come back to a normal or recovery?
Yeah, so he's asking about hormone recovery periods after the conclusion of hormones. Hormones have a lot of side effects. It's not chemotherapy. Okay, you're not going to be, puking, but they do have side effects. As I mentioned, it's the male menopause, which typically comes in the form of hot flashes, potentially even mood swings, some fatigue, and sexual dysfunction. I mean, that's probably the first thing that goes. Is sex is just out the window. Guys tell me they can have a model in front of them and they just don't get excited at all. And that's what it does. They may be able to get an erection, but it's just not of interest to them anymore. When we finish that course of therapy, the hormonal therapy, we then watch your testosterone recover, and it's variable in every patient. Sometimes we see full recovery in 2 to 3 months. Sometimes it takes 2 to 3 years. So it's very variable per person. We try to use agents to kind of stimulate things and get things going again, which could include just regular medications like ED drugs, Cialis or Viagra. Since they are constantly kind of working on the system, there's an interesting drug which is called cabergoline. And for any of those who have been on hormonal therapy with us, you'll find we use cabergoline pretty freely around here. It's an interesting, very interesting drug. It's only recently I'm seeing it now, in social media and what have you, people talking about it. But what it does, and the reason why we initially used it, is because in addition to testosterone, which feeds prostate cancer, there's another hormone that's created by the pituitary gland in the brain, and it's called prolactin. Well, prolactin is a powerful stimulant of prostate cancer. So a long time ago, we began using cabergoline, also known as Dostinex, as a way to shut down the prolactin. Now, prolactin doesn't really do anything for us except for some bad sexual side effects. So, for example, in men, as we get older, the prolactin levels go up, and but they're there all the time. And in men, there's actually a surge of prolactin after an orgasm, something that doesn't happen in women. And that's interesting because, as you know, men can ordinarily only have one orgasm. And it has a lot to do with the prolactin because there's a surge of it, immediately following an orgasm. And it just shuts down the ability to have another orgasm. Women don't have that surge of prolactin afterwards. And that's why we often hear about the multiple orgasms that women have. It's interesting. And so now, again, if you go online, you'll see that it's becoming increasingly popular in sexual forums, for obvious reasons, for men who want to have more potential orgasms, and it also prolongs the period of the orgasm. So it's very interesting without many side effects. So we use that for a dual purpose. We do it for one, shut down prolactin, which feeds prostate cancer. Secondarily, it could recover sexual function faster. But the answer to the question is it's very variable in men. There's another drug, we call them LHRH agonists. It's called Orgovix. It's a pill. And it appears that with the pill, which accomplishes pretty much the same thing as the injectables, which take away testosterone, there can be a faster recovery afterwards. The problem with the pill is that it's very expensive. You can forget about it. It's just another drug you got to take. Typically, the injectables, you get it, it lasts for a month, 3 months, 6 months, and it's out of and then it leaves your body. And many men like that. It's just more rhythmic and more known in terms of how long it's going to work. The pills, you're going to have to feather it and figure it out. But anyhow, it's variable. He asked if there are less hot flashes. Not really. They both bring on hot flashes because they both accomplish taking away testosterone. Here we use a drug, it's called estradiol, and it's a patch. Now, that's another angle that we take advantage of here, and that is that this patch called estradiol, and it's put on once or twice a week. Typically, we start off with twice a week, and it actually has pretty powerful anti-prostate cancer effects in and of itself. So that's a positive, okay? Secondarily, it works at the level of bone as well. So we like that because prostate cancer likes to go to bone, and or if men have dispersion or dissemination to the bone, it's working at that level. So we like that too. But the third thing it does, it really does help with hot flashes tremendously. And so we use it a lot here. We use a lot of interesting agents like that, so that many men who get hormones under, our umbrella here, we use them typically shorter periods of time, but we believe that that shorter period of time is more compact. And during that compact period, we're not only giving you just one pill or one injection, but we're giving you other things, which, like estradiol, doesn't hurt you. If anything, it benefits you from the side effect profile. And then, of course, having additional anti-cancer protective properties. Yes, sir.
How long after seeding is the prostate still inflamed?
So he's asking inflammation post brachytherapy. So we know that when you perform brachytherapy, you're putting these tiny little materials into the prostate, and the tissues right around it can get inflamed. And so what we try to do is minimize that by giving you drugs which are anti-inflammatory drugs. And that could be non-steroidals, like Advil, ibuprofen, or there is also prescription non-steroidals. It could be Medrol dose packs, which is a steroid formula that we use typically in everyone because it appears that there's an additional flood of inflammatory cytokines. And once they're around, they're kind of hard to get rid of. So we like to use the Medrol dose pack. But again, it's variable in terms of how long a person has inflammation. And it's probably going to be the worst between 4 to 6 weeks if you get it. And then it just starts riding out thereafter. And then by the third month, you're feeling pretty good. But again, these are all relative things. They're not severe. These are not things that, knock you off in terms of not being able to function or anything like that. It just may make you pee more, the inflammation, or you may have a degree of urgency that you may not have had before. We do try to also use medications for that as well. And there's a group of drugs. The common one we use is called Flomax, also known as tamsulosin or alfuzosin. And they're alpha blockers is the catchment word that we use. And there's stronger ones too. So for those patients who have more of those inflammatory side effects, we go up the ladder from Flomax to alfuzosin to doxazosin to terazosin, and rarely have to use things like dibenzoline, but we have quite a number of those drugs that could be beneficial. It doesn't hurt also for those of you who've had brachytherapy to be mindful of your diets, because that plays a big role in it too. So, after brachytherapy, if you're drinking a lot of coffee, well, coffee is a bladder irritant. And so it's just going to make matters worse. And, but some guys say, well, it's worth it. I'm going to have my coffee. I need that wake up. And if it means I got to pee a little more, so what? So that's fine, and I get that. But it is inflammatory, as are the tannins and teas can be also inflammatory. And then of course there's carbonated beverages, probably the worst. Carbonated beverages really cause a lot of bladder irritability. Alcohol is a known bladder irritant. So these are things. Even chocolate is a known bladder irritant. Dark chocolate less than regular chocolate, but these are things that you just need to know about. And there are things you could also do dietary wise that could reduce inflammation. And that has to do with healthy diets. So for example, we know avocados, if you like them, powerful anti-inflammatory foods, probably the most. Maybe the only one that comes close to an avocado a day would be extra virgin olive oil, very powerful anti-inflammatory food. So, yes, sir.
Will the energy levels pick up after hormone therapy?
So yes, he's asking energy levels after hormonal therapy. Typically, they do pick up as your testosterone recovers. Now, I mentioned the next generation drugs, okay? And I mentioned the Johnson & Johnson product called Erlita, and now there are 4 of those, okay? And it's interesting because we didn't have these that long ago. And while they tend to have less side effects from the perspective of not taking away testosterone, allowing testosterone to recover, unfortunately, there can be a fatigue side effect. And that could be their major side effect. And that's Erlita, that's Nubequa, that's abiraterone, and Xtandi. And they all kind of have the same thing. There can also be a little bit of cognitive function that people talk about with a second generation or the next generation drugs. So it's a price to pay to get rid of cancer, the prostate. And again, it's not chemotherapy, and I know because I've had men who have been treated with chemotherapy for lymphomas and things like that, and they'll go through the hormones and with bad expectations, but then they'll tell me, well, that was a piece of cake, compared to chemo, where they're sick all day and they can't really do anything, and they have to nix their schedule because they can't golf, they can't play tennis, they're a mess. It's completely different. You can usually function. And I know it's easy for me to say, but I am here to eradicate prostate cancer. Anyone else? Yes, sir.
When you have
an elevated PSA and you've done a diagnostic test, then you go in and go for a sample to make sure it's cancer, you kind of disturb the cancer. Don't the rest of the cells migrate through your body at that point?
So he's asking a question about prostate biopsies
Right.
and the potential for actually spreading prostate cancer. So there are different types of prostate biopsies. The vast majority of prostate biopsies are performed through the rectum. They're called transrectal ultrasound-guided prostate biopsies. These are the forms of biopsies that urologists are trained in their programs to do. And because of that, 99% of biopsies done in the United States, maybe a little higher, are transrectal ultrasound biopsies. There are pitfalls associated with that. I'll try to explain it. So if we're looking at a side view of the prostate, so in the back side of the prostate, so this would be your front and this is the back, and the back side is the rectum. And it's a tube that parallels the prostate. And here's the anus right here, okay? On the front side of it, well, there are these perches we call seminal vesicles, which are the reservoirs for seminal fluid. And then, of course, the urethra runs right down the prostate and then empties into the bladder, which sits over here like that. But here's the prostate. And so the thinking being is, well, the fastest, easiest way to get to the prostate for a biopsy is to go through the rectum. So what's done is a probe is put into the rectum, and then through that, the probe jettisons out these little needles, and the needles go like that, okay, through the gland. There are some problems with that. Number one, if someone has an enlarged gland, as many men do as they get older, and what if the targets are here? Because most men have already had an MRI scan, and it says, okay, we see a cancer in a certain location in your prostate. What if it's over here? Well, these needles may not reach that area. And so that's a problem, okay? So it's a geographical problem. You just can't get to it. The second problem has to do with the fact that this rectal wall is laden with bacteria. And you could do as many bowel preps and Fleet's enemas as you possibly can, and you'll never, ever sterilize the rectal wall. And so 100% of the time with transrectal biopsies going through the rectum, you are introducing bacteria into the prostate. Now, does everyone get infected? No. As I often say, this room was filled with COVID people. Would we all get COVID? No, but about 20% of us would. Same thing here, about 20% of men who have transrectal prostate biopsies end up in an urgent care or emergency room within 36 to 48 hours with an infection. 5% of them actually end up in the ICU because the infection became bloodborne, meaning it left the whole region of the urinary system. Most get urinary tract infections or prostatitis. But that's a big, potential problem with prostate biopsies. And then there are other issues like there's big nerves. So the rectal wall has these large nerves associated with it. After all, our rectum has to tell us about our bowels, our stool. And so it's very sensitive to things like that and requires a lot of nerves in it. Well, when you do prostate biopsies through the rectum, you can't avoid but to hit those nerves. And that's a problem because, hopefully you're anesthetized during the procedure, but afterwards it could smart. And men tell me, it could smart for 10 to 14 days. It hurts or it throbs because you hit the big nerves. There are nerves, by the way, in the prostate too, but they're smaller. They're much smaller. So if, when they're engaged, there's not a whole lot of pain. They may be uncomfortable, but it goes away pretty quickly. And then finally, to answer your question, there's also really big vessels in the rectal wall that communicate more widely with your bloodborne circulation, your liver, your lungs, your bones. And so what happens is, let's just suppose there's a big cancer sitting here and you go in with your needle and bring it back out. Well, this potentially intermingles with the blood of the rectum and can disperse cancer. And it's been very well documented in the medical literature. It's a small percentage, but it's a real phenomenon. Okay, I I don't discourage men who have to have it that way from not getting a prostate biopsy, because I think it's a very small percentage, but it's a real phenomenon. It can happen, and that could be concerning. The other way of doing prostate biopsies, which is the way I do it here, is through an area called the perineum, which lives right here. And actually, the scrotal sac is here, and the penis, and so on and so forth. But the fact of the matter is, this area here is skin, so it can be completely sterilized, and so risks for infection are next to nil. It just shouldn't. It shouldn't happen. Secondarily, there's nowhere that I can't go to. If there's a location in the front of the gland and the patient's prostate gland is large, I can get to it. The third thing about it is I'm not engaging the big nerves. So if I do engage nerves, they're small nerves in the prostate, and they're small. So the discomfort is minor. And I also do something called a periprostatic block right at the conclusion of my procedure. We do them here with called twilight anesthesia, where if you've ever had a colonoscopy, it's just kind of lights out. But before you wake up, I've done a block, so you don't really feel much at all. And then the fact is that if there's any bleeding, it's not communicating with the outside world. And so what happens is, if there's blood in the urine, it migrates back to the urethra here, goes into the bladder, and then you just pee it out. So it's a closed loop. So no one has ever published a single document of men undergoing transperineal, which is this form here, which is transperineal prostate biopsies. No one's ever, not a single case report in the literature suggesting that a transperineal prostate biopsy caused prostate cancer to spread.
What about the spread of the cancer cells when you're taking that biopsy sample? They tend to, I don't know how it works, but I would just think of them as being somewhat encapsulated, that cancer, and now you break it open.
No, he's asking about dispersion maybe within the gland. Again, cancers are amorphous. They're not so well defined. They're already moving their tentacles around the gland. I wouldn't be so concerned about that. It's the bigger picture is if it causes spread to other parts of your body,
Right.
which again, it can if it's a transrectal prostate biopsy for reasons I've discussed. But if it's transperineally, it's just not the case. Okay. Anyone else? Yes, sir.
How long does the hormone treatment last relative to the darts and bacterial?
So he's asking the question, the duration of hormonal therapy in the context of patients having DART and brachytherapy. So I try to identify, each particular patient with each particular cancer, and to be very careful about making a hormonal regimen that suits the cancer. So we typically lean on the lesser side here in terms of the total duration of hormones for reasons that I've told you. When we do them, we're more compact. We use more agents, which don't necessarily increase side effects. If anything, they could decrease side effects, but we use more agents. Also, there's a large body of data looking at hormones and radiation. So how do they work? Well, radiation causes an injury to the cancer's DNA. It breaks the strand, okay? And that's important because the cancer can then wither up and die, and they often do, but some don't. And some cancers are resilient. They're always looking to recover. So it appears that hormones don't allow that recovery. So given simultaneously, it appears to be very beneficial in men. And there's been a lot of data through the decades in terms of how to give hormones. Do you give it before? They were giving it 2 years before even beginning radiation. Do you give it before and during and after, just after? And if you really break out that data, you find that it's the during tends to be the most important. But you also have to be cognizant of the fact that if you finish radiation today, the radiation hasn't stopped working, and it won't stop working for a while. And that could be 6 months from now, it could be 2 years from now. And so we have to come up with a plan that suits your needs, your particular cancer. Certainly, a man who has localized prostate cancer in the gland itself, or maybe just having some small element escaping the prostate, he may require less hormones than the person whose cancer has escaped elsewhere and has gone to other parts of the body, especially bones, where prostate cancer has this propensity to go to. Because then we have to be mindful of the fact that, sure, we're taking care of the immediate effect of the radiation breaking the DNA of the cancer and not allowing it to repair. But what about those bones? And what about those lymph nodes? What's going on there? If we're not treating those lymph nodes, in other words, maybe distant lymph nodes, which are commonly involved with prostate cancer. So we do have to be mindful of that. Some patients don't get any hormones at all. Okay, and I have, my group of people who don't, and they're more favorable categories. And I'll never decline a treatment because I realize that radiation that we deliver here, the DART and the brachytherapy, has pretty acceptable side effects. Hormones could be more. And the benefit of hormones, it's small. It's not a giant effect, but it's real. Okay, it's a very real effect. And as I say, the more advanced the cancer, the more real that becomes. But there are guys who just say, I don't want it, and they realize, well, there's a potential cure, eradication, or remission without it, and I will treat them based on that. But there's a real event that happens, and the second line agents that I mentioned, the next generation Johnson & Johnson agents, they work through another angle of not allowing the cancer's DNA strand to recover. So it's kind of a double. It's ganging up on the cancer. And that's the reason why we think that men with higher risk aggressive cancers could benefit from the duo of primary hormonal therapy, which again, I told you initially doesn't allow the DNA to repair, but also the second generation, it has another way of doing that. And between the two, the cancers don't have a chance. And so that's the reason why we use, if you hear about these next generation drugs, in your particular case, while we're using them. Yes, sir.
That one, that two, that three, what that mean?
He's asking about the different phases of DART, so we typically have different phases and their purpose is different. The first purpose may be to target the prostate and the immediate tissues around it. The second phase may be to target the immediate draining lymph nodes around it, or we call it paraprostatic tissues. Then the third phase means that we're targeting things that we determined with phase 1, phase 2 needs higher dose levels. So it's just changing our plan around. We don't like to be stuck in the mud, and many places will do a plan and just stick with the plan from beginning until end. And I think that's probably, again, 99% of the facilities will do one plan for prostate treatment and just stick with it for 8 or 9 weeks. And we don't do that. So we do stop, take a look, replan, start with another phase. It's just the way we do things here. Yes, sir.
It seems like most urologists believe in removing the prostate. What's the advantage of keeping the prostate versus having it removed?
He's asking basically about radical prostatectomy versus other forms of therapy. Okay, and to describe that, first of all, let me say the urologists, again, just as they were trained to do transrectal biopsies, and that's what they do, hell or high water, they've been trained to remove the prostate surgically. That's what they do, okay? And that's what they do. But the prostate, we just showed a side view. If we're looking at it straight on, looks something like this. And the urethra in this picture runs right down the center. right here is a big valve that we call the external sphincter. I'm sorry, the internal sphincter, and it's actually part of the bladder. And it's just this part of the bladder, the very bottom of the bladder, because the wall thins out. But right here is a big muscle sphincter. Sphincters are muscles in our body. We sometimes call them valves. But this big valve here is responsible for controlling urine. Meanwhile, between the bladder and the prostate are these appendages that we call seminal vesicles. And, the prostate is a sexual organ. It's the G-spot in men. It has a lot to do with the orgasm. It carries the nerves that go to the penis. And so it's purely sexual, but it also makes the ejaculate and then stores the ejaculate in those reservoirs above it. Well, with cancers by and large, okay, and I was involved with many other types of cancer operations before I got involved with the prostate. And I did do radical prostatectomy, which is currently done with the Da Vinci robotic procedure. I did that. But let's just forget about this picture. I'm just going to use this window here. So if this is a cancer anywhere in the body, and it could be anywhere, and we may look at it, or it may feel like a lump or a bump, and it may look like some black spot, on a MRI, CAT scan, or ultrasound. But what we also know is when we zero in on it, they rarely have these well-defined borders when we zero in. And microscopically, they have roots, because that's what cancers do. Cancers do three things. Number one, they grow faster than the parent cell wherever they arise. If it's the prostate, they're growing faster than the parent prostate cell. If it's in the lung, they're growing faster than the lung cell. That's what cancers do. The second thing they do is they invade surrounding tissues, and they do that early on. And the third thing they do is they spread to distant organs. They gain access to the vascular networks in our body. Because of this principle, when you do a cancer operation, and I did a lot, tongue, lung, brain, breast, gynecologic, I knew, and we knew with the principles of cancer surgery, was that we shouldn't just remove this, because if you did that, you'd be left behind with, this is gone, but those tentacles are still there. And that's a problem. And so when you read into the archives of oncology or cancer operations, principles of cancer surgery, you'll find that you never do that. You always go wide. That's how you do a cancer operation. And when you do that, you also go out of your way not to spread any blood. The thinking being is if you commingle your normal blood with the cancer, that's tantamount to spreading it around. So those are two major principles of cancer surgery. The fact of the matter is you could typically accomplish that. If you had a cancer in your liver, you could take a big chunk out of your liver. If you had a cancer in your lung, a big chunk of the lung, if not a whole lobe. Even breast cancer, it could be a BB-sized tumor. You take something the size of a lemon. You could accomplish those things, but you can't do it with the prostate. And the reason you can is the prostate is surrounded by too many critical structures. So again, the bladder is on top of it and then falls in front of it. I've already shown you the picture of the side view of the prostate where the rectum is behind it. Then you have these big nerves, arteries, and veins called neurovascular bundles running on the right left side of the prostate. And then down here is we call the urogenital diaphragm. So this urination through the prostate urethra, which all urine has to go, comes down this way and then exits here. And there's another group of sphincters right about there. We call those the external sphincters. Internal, external. The externals are really small in comparison to the internal sphincters. And then, of course, the urine continues to go out and eventually to the penis. But the problem with prostate cancer is that there's just too many critical things around it. So if you think of this picture in context with this picture, most prostate cancers begin on the edge. And I think if most of you look at your reports, your MRI reports, it's going to say it was in the peripheral zones. If you look at your biopsies, it's going to say biopsy from the peripheral zone. The peripheral zone is the edges of the gland, this area here. They don't typically begin here or here in the central zone. The problem with the prostate tends to be it does not have a capsule. And most organs in our bodies do have capsules. And just about everything in the urinary system has a capsule. You can just think of a capsule as a shell, a casing, okay, that cancer's got to bore their way through before they gain access to the outside. Prostate has no capsule. So these cancers, while they will find their easy time going inward, they'll also find an easy time going outward. And meanwhile, if you just think of this picture, you would say, well, for me to surgically remove this in the spirit of this, the way I did this surgery, I got to take a big, area like that around the prostate. But if you did that, you're removing your bladder, your rectum, you're removing the urogenital diaphragm and the sphincter and the vessels going to the penis. No one does that. No one will ever do that. And so the way prostate surgery is done is it's peeled off. In the process, however, you do have to remove the internal sphincter. Got to go. Can't leave it behind. It's got to go. That's been your control valve your entire lifetime. Now you have to rely on a really small sphincter down here to get the job done. And that's the reason why so many men who've had their prostates removed surgically suffer from incontinence and leakage issues for the rest of their lives. And meanwhile, of course, the prostate being a sexual organ is gone. So usually that's part and parcel also. I've recently been hearing about this, well, again, and just going back to this picture here, if you think about it, you've removed, you can't do that. So what you do is it's just being peeled off, and you can't remove what you can't see. And so these tentacles here are left behind, and next thing you know, your PSA is rising again. And while the urologists, and I know just about everyone, when you first see them for your interview with them, they're going to say, well, you should have it removed because if you do radiation, you can never have prostate surgery again. And that's a myth, but it works. It's a great scare tactic. Anyhow, so failures are, again, many men think, again, I'm going to go through this operation because he said it's going to be one and done. I never have to deal with it again. Boy, is that a mistake. Okay, it's not true. And then when it does come back, then suddenly, they're talking about the greatest thing since sliced bread called radiation to clean up the area. And it may be too late because they may have spread the cancer. So for all those reasons, I don't like doing surgery. I think the complications are too high. The failure rates are very high. And, it just lends itself to all kinds of big problems. Lately, I've been hearing just from a few patients talking about this nerve sparing procedure. And I don't want to state who's saying it, but there's a few out there now talking about it. And I just say beware, because 20 to 25 years ago, the group at Johns Hopkins in Baltimore, Maryland, big group, well-known surgeons led by Patrick Walsh and Valentine Carter, very excellent surgeons. What they started doing is saying, well, we know we're getting a bad reputation because every guy has ED, sexual dysfunction, 100%. Okay, so let's make better of it. So what they started doing is sparing the nerves, and they called it a nerve sparing procedure. And, they're a big institution, and we're all watching them, and some other institutions, including where I was at Sloan Kettering, started doing the same. Well, what happened was we came to recognize that the failure rates start getting to be really, really high, above and beyond what we ever expected with the regular radical prostatectomy. It got a very bad reputation. It started to be called not only nerve-sparing operation, but a cancer-sparing surgery of the prostate. And so it was dropped, and it hadn't been done for a very long time. But I've recently heard it, from a few patients that I've spoken to, being offered that again. So it's coming around. It's just revisiting the wheel. But we had it before, and the results are going to be the same. You're welcome. Anyone else?
After the seed implantation, can you return right away to your normal activity?
Yeah, so she's asking about recovery after seeding, and yeah, we don't put any restrictions on you. I would suggest for a day or two taking it easy, but after that, you could do pretty much anything. Remember that with seeding, there's no cutting. There are no incisions, okay? And frankly, a biopsy is more traumatic because with biopsies, you're removing tissue, so the body perceives that as a little more trauma than putting these tiny little materials in. I can usually complete a brachytherapy or seed implantation procedure within 15 to 20 minutes, max, and without a lot of blood at all, and without touching the nerves, without touching that big internal sphincter muscle that controls your urine. So, when I started doing brachytherapy at this big hospital in New York, where I had a lot to do with the pioneering work of it, it was light years different than surgery, and I realized that right away. That what I could accomplish in a matter of minutes would take me hours with a scalpel, but I didn't have to use a scalpel, and there was no blood spillage, no incisions, no, leaving and leaving the prostate intact too. So leaving it intact may be important as well because it has a purpose, it has a function in our bodies. That function continues. Having said that, again, the prostate's a fickle organ, and it is a sexual organ, as I mentioned. And sometimes you just quite don't know what you get. You could do just about anything to the prostate, and guys could end up having like erectile dysfunction. Okay, and you scratch your head. You say, "Well, I don't know why. I left the nerves intact. I left all the apparatus around the prostate intact." But it's a very fickle organ, and there's a feedback mechanism that goes on between the brain and the prostate and the sexual function. But the vast majority of patients who have our types of treatment, DART and brachytherapy, retain their sexual function. The one thing that I do find, and I find this on follow-ups, that most men will say in their follow-up, they have no problem getting an erection, but their ejaculate is diminished and changed in consistency. And that's pretty common. I'd have to say 80 to 90% of men have that. Okay, now they're still fertile. And the reason why they're still fertile is because the testicles down here are still making sperm. And so I've also had a lot of guys, through my career tell me, "Dr. Dattoli, you never told me I was going to impregnate this lady." I mean, I was like, "I never told you you couldn't because you still are fertile, okay, after brachytherapy." But I think many men tend to think they're not, and so it could cause trouble. But anyhow,
Also, I don't know if you know this or not, but the patches that you use is for hormonal. Can they be purchased outside if, like, we purchased it back in Canada? Are they available there?
she's just asking about those patches and where you can get them. I understand they've become a little more difficult, but yeah, I think anywhere you get them, they're the same thing. They've been around for eons. They really have been, and it shouldn't be a problem at all. Yeah. But they're very interesting in their mechanism of action. I especially like to use them even in men with hormones who complete their hormones. And sometimes, especially if guys have bone metastases, I like to maintain them on the patch because it doesn't have a lot of side effects, but it really works at the level of the bones. We use other agents too that work at the level of bones. Some of you may know of it. One is called Exgiva, another is called Prolia. And it appears that we know prostate cancer has this propensity to find a home in bones. It's just a thing with prostate cancer, and it does that. And there have been studies which have documented that there's a reduced rate of spread to bone when even initial treatment, whether that initial treatment was radiation or surgery or whatever, to be on a drug called Exgiva. It's got a little brother called Prolia, and they do something in the level of bone that inhibit the ability for the cancer to find a home in the bone. It's an enzyme or protein called RANKL, and it disrupts the RANKL mechanism so that cancers just have a more difficult time. We use that in men with high-risk disease, and we often call it Prolia. In men who have cancer that we know has spread to the bones, then we use its bigger brother called Exgiva. And again, for the disruption of that RANKL enzyme, and it works at the level of an osteoclast. Osteoclasts are what are used to break down bone, and it inhibits that from happening. Anyone else? Yes.
The cognitive issues,
Yeah, so she's asking about cognition, from hormones. And yes, they can, as I mentioned, they can, give mood swings and some guys will even get some forgetfulness out of it. And it's a temporary thing. So once the hormones are out of your system, then you should be good to go. It's just and again, variable time frames. It's hard for us to predict exactly how long, that may take to get out of your system. Not everyone gets it. There are other agents, even next generation agents that we've been using, which have less in the way of cognitive impairment.
Quick question.
Yes, sir.
The dispersion of the seeds, is it uniform at first, or is it
Yeah, so he's asking about how the seeds are placed. And there are different styles. Many places put the seeds uniformly through the gland. Okay, and what that basically means, it's called a uniform seed implant, where you put seeds uniformly. So every seed is equidistant to every other seed in the prostate gland. And a long time ago, when I was developing brachytherapy at Sloan Kettering, there was a group that began in Seattle, Washington, and we came to call them the West Coast Experience. We ended up calling ourselves the East Coast Experience. The West Coast Experience, they put their seeds uniformly. But what I was identifying was that those guys had a lot more side effects with respect to urination. Now, if you just think about it, and the easiest way to think about it is, if these were all electric heaters, now the center of your gland is your urethra, where a lot of side effects can happen. With brachytherapy, we call that an inflammation, urethritis. Well, if you have electric heaters surrounding you and have these contributing to even these and these, you end up with a really high dose in the middle. And we did studies and identified that the central dose, where the urethra lives, can get between 8 to 16 times the dose. So in contrast to that, I don't do it that way, and I really never have. And we began doing what's called peripheral loads. Now, with peripheral loads, what you do is you basically just put them in the periphery of the gland. The thinking being is that if you're sitting on a couch here where the urethra is, you're still getting a contribution of all of those electric heaters, so it's still going to get pretty hot. But our objective would be for this area to get a uniform dose, just 1-to-1, or maybe even less. What I do today is I do a modified peripheral, and then I'll put higher doses right in the tumor, like that, in it and around it. Okay, and we can do that because we have instruments here which enable us to do it, called three-dimensional color flow power Doppler ultrasounds, which enable me to watch the gland as I'm implanting it in real time and with color, with Doppler, so I can actually see the cancers and not only say, well, you know, the cancer's on the left side, I'm going to give the left side a higher dose. No, I can see the cancer. And sometimes they're not so obvious anymore because you've gotten dark, but we can still see the remnant of the cancer. And I plug it specifically with these tiny little seeds. So it's a tumor, a hyperdose to the tumor again, or dose escalation to the tumor. Anybody else? Yes.
Have you looked in like taking that like some of the off-label drugs like metformin or ivermectin?
Yeah. So she's asking about drugs beyond the hormones, and even here, we commonly recommend drugs like metformin. Metformin has anti-prostate cancer effects, especially for prostate. More recently, we've looked at a supplement called berberine, which actually has the same mechanism of action as metformin. And, you know, men like not to have to take so many prescriptions, so the berberine works well. So we use that. There's also a drug called Celebrex, and Celebrex is an anti-inflammatory. It follows what we call a COX-2 inhibition pattern, which also has anti-cancer properties. So we commonly use that, and that's welcome because, again, we're talking about inflammation, so we can use an anti-inflammatory agent like that, but it is a prescription. Now, above and beyond that, there is a whole new realm of drugs that was identified. A lot of them came out of the pandemic, you know, but ivermectin, which is an anti-helminth, meaning anti-parasitic drug, and others like it, fembendazole and mebendazole, and they have been identified to have anti-cancer properties. And I'm not opposed to them at all because I don't see side effects from them. So I've had many men, on ivermectin or fenbendazole, they do have anti-cancer properties, but I'm not seeing side effects, like liver problems or anything like that. We just haven't seen them. So we're not opposed to them. So the answer is, yeah, they're fine. They could be the same as Celebrex, or, I can't prescribe them because they're not labeled for cancer treatment. So you have to get them elsewhere, and I know people get them on the internet, or you can get them from some Indian pharmacies and things like that. And I have no problem with it. I would like you to tell us if you're taking them, just to let my staff know, just in case we do see something, and it needs to be addressed, as a result of those drugs. All right. Well, I think that'll conclude our meeting. Thank you all for coming, and welcome you back in about a month from now. All right.